No. So for sake of time, I'd like to invite up Dr. Hricak again. So she's a professor of medicine at Memorial Sloan Kettering. And we're going to ask her to give a brief review of the wonderful workshop that we did this past February.
Thank you, Chris, and hello again. So the workshop was improving cancer diagnosis and care, and it dealt with oncologic imaging and pathology, and both with expertise and access to technologists. As you know, IOM, or now NAM, has been very interested in diagnostic care and improving overall healthcare. So in 2015 report, there was call to action that diagnostic process and understanding it's complex, collaborative, involves clinical reasons and information gathering. Well, I can tell you at the end of our workshop, it only becomes more obvious. There are two elements that we need to improve. One is human, which is called we don't have enough oncologists in any specialty. A second is education, and third is collaboration. And most of all, I do believe that future medicine lies in integration of human elements and technology. So diagnostic imaging, a critical component in cancer care, the president of the NAS, Zhao, said in 2016 report on precision medicine that diagnostic tests influence estimated up to 70% of all treatment. Now, this is medicine in general. In cancer, I think it's much higher, and specifically for imaging, it's absolutely essential in almost every cancer. Some of dermatology can go to treatment without imaging, but that is an exemption rather than the rule. Imaging is at every step of cancer care, and it really has evolved with a cross-sectional imaging for screening, cancer detection, localization. It wasn't long ago we did virtual laparotomy to make the diagnosis. Today it would almost be a malpractice suit. And then today what we do prior, we really look at, can you start the, thank you. There is no reason to virtual laparotomy anymore as we have a cross-sectional imaging. The same in treatment follow-up. For most cancers, especially those that don't have biomarkers, imaging is the way we look if the cancer has responded. But that was imaging that will always stay essential. But in a way, anatomy is imaging of yesterday. So we are moving in molecular imaging because today in cancer care, it is all about molecular biology. I'll give you an example of a CT scan that has, they are all arrows, has soft tissue masses, and also obviously has a blastic bony metastasis. When you do molecular imaging, which is FDG, PET-CT, which is glycolysis, the lesions in the soft tissue enhances, picks up, or has a higher SUV value, which means there is a higher glycolysis. The bony lesion doesn't. But when you give androgen receptor, the bony lesion now has high SUV, high uptake, but the soft tissue doesn't, which means that just as Chris says, for precision in therapy selection, we need more than genes. We need integrated approach. And imaging in vivo is a really in vivo companion diagnostics. This patient will not do well or will not have total response with a single drug. He obviously needs, it's a prostate cancer, that's why it's he needs 2 drugs, a cocktail approach that really through imaging we can see. Imaging plays a huge role in drug development. This is a patient, it's a female, it's a breast cancer patient On the baseline study, this is estrogen imaging. There are multiple bony metastases in the spine. Following the drug, the GDC 0810, there is a superb response. So why imaging in drug development? It's not only for patient selection, for selection of the therapy, but in drug development is pharmacodynamics to monitor and optimize target engagement. So Chris was saying how it's a blackjack sometimes when you decide on therapy. Well, I believe that 10 years from now, when we look back, how we test and how we prescribe new drugs going to maximum tolerated dose, which means in the drug escalation, in the phase 1-2 studies, we keep giving more and more drugs till patients can no longer take it. We never ask ourselves, what's a biology relevant dose or minimal tolerated dose? Through imaging, that is possible. You have to use targeted drug, targeted images to see if the receptors have been, such as in this one, total suppression of ER. So therefore, instead of 800 milligram, we went down to 600, and that's how the drug was continued. So imaging, in vivo imaging, molecular imaging, is essential in patient-centered, value-driven population health, and imaging in drug development is now slowly being accepted around the Western world. And then the ultimate, just show you potential of imaging, is really theranostics. When in the same molecule, depending if you're using tracers such as gallium in this case, or you are going to use one for therapy. So in this patient on imaging, this is a neuroendocrine tumor. There are multiple metastases in the liver. The drug that was recently approved, Lutathera, has the same molecule. It's just that now it has lutetium, so therefore has a treatment, and you can see excellent response. This is really ultimate as we go forward. Not every drug can be turned into theranostics, but many, many are coming along. So if everything is so great, where are the problems? The problems are, number one, education. As we look at diagnostics, pathology on average has 6% of cases that go to malpractice suit, and radiology has 18%. When you look at more details, it's really misinterpretation of those images. So for both pathology and radiology, we have superb technique, and we make unbelievable errors. The first slide was from Hricak, so those are malpractice cases. This is a summary of diagnostic errors in radiology, in oncology. What change in management when the same image is read by oncologic imager? I think that when you look at change in management of 26%, 38%, the one in breast, 53%, it's really, really unacceptable. And that is our problem. Problem is purely education and understanding. And we do believe that machine learning may help in that, may guide you in the right direction. Also, misinterpretation in diagnostic imaging studies. For many years, we said it was all about breast cancer and mammography. That's not the case any longer because of a wide use of imaging. In oncology, the number one reason for malpractice suit today are CT scans. CT scanning in radiology has more or less replaced plain films. Yet people don't know how to read it. And that is almost dangerous because you have security of the modality, but you misinterpret, actually cause greater harm. Another case that we really have to discuss, where are the radiologists? There are counties with no local radiologist. All of those in white have no local radiologist. Without technology, we will never solve that. Second, all those in greens have only general radiologists. Today, radiology demands subspecialty because technology is so prevalent. It is complex. You are no longer able to read the head and the chest, abdomen, and skeletal. There's no way. And then, of course, as always, the two coasts have subspecialty training. But this map, I think, says it all. So less populous and more rural counties have fewer or none of the radiologists, and we need technology to try to connect and do good. So what were the action items? Number one is improve education and training. So for those that we have to improve education and training. And that starts from the residency program all the way up. We have to expand access to expertise in oncologic imaging, and that expanding access, only technology can help us through teleradiology, second opinion networks, tools and mechanism for imaging in the cancer centers. We absolutely have to engage, create oncologic imaging expertise within radiology departments. You have many academic radiology departments today that have no special expertise in oncology. Increase integration and collaboration among specialties in cancer care. You are a much better radiologist when you work in a multidisciplinary team, when you understand clinical questions, when you can issue clinically relevant reports. In isolation, machine learning is going to do much better than any radiologist. Improve and adapt use of clinical decision support system. Basically, life today has to be evidence-based. And then support innovations. This is really what this workshop is all about. Look at innovation, support change, develop this together, improve that data curation, integration, and sharing. So there are a number of extremely well outlined action items. They are in the proceedings of the workshop, and I would encourage you to please look at them because each and every of us can contribute to make this better. Pathology has very similar problem. Should there be mandatory review of all new cancer diagnoses? I think in most places, especially in cancer center, it is. The use of checklist for pathology, such simple things that are really organizational and human elements. And then the very last one, just like Chris said, we really need integrated diagnostics. We need integrated diagnostics because cancer diagnosis is a team effort. And it has convergence of life science, physical science, engineering, and beyond. Look at the complex part that goes and it enters new specialty to medicine that's becoming crucial, and that's really computer science and engineering. We cannot move forward without them. Imaging as well as pathology are only two elements. So what do we need in integrated diagnostics? We need measurements that are quantitative, that are multidimensional, that are dynamic evaluation of cancer. And we really need those measurement domains to be standardized and quantitative. The second part, we need integrated analytics. The future of medicine is in our ability to use computers to really give us the result. Computable data, we need to connect databases, and we are really not there. And then, only then, are we going to have true predicting modeling. So it isn't surprising that the single gene, single drug didn't work, because there is much more to that cancer, to the environment, to the stroma and to the body, to the age, to the sex, to so many different things that we have to include clinical informations. And only by proper predictive modeling are we going to have personalized treatment, then learn and loop back. But this is the future of precision oncology. Unless we work together and put those elements together, it will always be one gene, one drug didn't work. So the radiology and common themes, there is a complexity of cancer diagnosis and treatment, requires multidisciplinary approach on human side and the data side. We have integrated teams of oncologists, surgeons, radiation oncologists, pathologists, radiologists, then advanced providers, APP nursing. But we have to have biomedical informatics. They can no longer be in a different building, in a different far way. They have to be with us and understand the questions that we are asking, the same way as a radiologist has to be in a team. It cannot be alone in the basement as it used to be. Governance has to change. We have to have formal multidisciplinary governance structure where the engineer and the computer guy have to come and be with us. It's no longer optional. Measurements, outcome, we need to measure and then plan accordingly, because human is to error. And you learn by errors, you don't learn by your successes. Essential requirements for quality improvement, we have to have culture that's punitive. We have to have culture that we understand and respect each other's knowledge. Very often we don't. What does he know? He knows much more what I don't know. So respect each other. Infrastructure, data system, and leadership. We have to have leadership, both clinical and operational, that understands that our future really belongs and will only be bright if we have integrated diagnostics. Thank you very much.